Kia ora. Thank you so much for inviting me back to New Zealand. I was here with my husband last year and learned a little bit about your people and your land and the healthcare of your nation. And certainly I feel that I'm a learner today. I hope I will leave some ideas with you, but I'm going to take a lot back with me. In the very moving welcome this morning, there was discussion about the winds of change, but also the enduring commitment to families and to culture and to values. And that shapes a lot of what I want to share with you today. I bet you can relate to my feeling right now that having to follow Maureen and Don is a daunting task. Inspiring leaders, both of them, and I hope I can build on the ideas that they have shared with you. As Jillian, who's been so gracious and so supportive of this work of really involving patients and families and enhancing quality and safety with the new commission, I hope that the Institute can be a resource to you. There's a section on primary care. There's a section about involving patients and families in this work of improvement. And so I hope that you will come visit us often and share the innovations that are happening here. I feel a personal connection to each of you in the room. I have 4 children, 2 of whom work in primary care. My daughter is a lead physician in a safety net clinic and doing all of her work in Spanish. And my younger daughter is a nurse practitioner and is committed to working in a similar kind of setting and doing her work in Spanish as well. So I've been asked to talk about patient and family-centered care and what that looks like in health services, the benefits and how to get there. And so in our time together, I'm going to try to develop a shared vision of what patient and family-centered care looks like and how it can be applied in your practices and in the regional networks that support your practice so that you can be supportive in the kind of change that moves your organizations to really understand and work with the insights and perspectives of patients and families. I'll try to share some of the benefits of this work and what you can actually do. So I hope we're going to travel fast and look at lots of things that are happening now in the United States. And I hope it will just fuel your innovation of thinking differently about the way you work with the patients and families and how you really learn what their insights and perspectives about the healthcare system are. At our international conference in June, Don really reinforced this concept that patient and family-centered care, that engagement of patients and families in care, but also as improvement partners, is essential to achieving the AAA. So what really is patient and family-centered care? We think of it as an approach to the planning, implementation, and evaluation of healthcare that's grounded in mutually beneficial partnerships among patients, families, and healthcare professionals. And there are really 4 key concepts, and probably most of them will seem to you like this is just high-quality healthcare. But there's one that I think may be a little bit different for you. The 4 core concepts are respect and dignity, information sharing, participation, and collaboration. Respect and dignity means respect and dignity for everyone, for all patients and their families, no matter what kind of difficult circumstances they may be living in. It means respect and dignity for everyone who works in the practice, who works in the hospital, who works in another community organization. This approach to healthcare is really grounded in communication and relationships. The second core concept really deals with how we share information. Information is critically important to patients and families, and it matters how we share it. We share it, and this is what we've learned from patients and families, that we share it in ways that are useful and affirming. Complete, unbiased information shared in ways that that are useful and affirming. And that means you really have to connect with patients and families and find out how they learn best and how they want that information. The third, and we know we get the best clinical outcomes, and certainly Maureen talked about it with the 5,000 hours that a patient living with a chronic condition manages their health care. And so we need to encourage and support the active participation of the patient and family in their care. But we have to connect with them at the level they choose. So again, it's building a relationship and understanding the patient and family in the context of their lives to work together to encourage that active involvement in care. And then the last concept, it's collaboration in the clinical encounter. But the part that I think may be a little bit different for each of you is this collaboration in primary care redesign, in primary care improvement, in educating the next generation of primary care clinicians. Collaboration in research that you do as you go forward, that patients and families can bring their insights and perspectives and wisdom to this work as well. So that is really at the heart of the practice of patient-family-centered care, is this collaboration. A simple way of thinking about it is patient and family-centered care is working with patients and families, not just doing things to and for them. I think it's very important the language you use also. Particularly, your country is very diverse, as is ours. And individuals define their families differently. But we know that however they're defined, that they can play a useful part in care and keeping people healthy, promoting well-being. And we know that social isolation is a risk factor. So we need to be specific and articulate that we are working on both patient and family-centered care and looking to the patient and the family to define their roles in care and decision-making. If you think about your practices, probably the people you spend the most time with are the very young, the very old, and those with chronic conditions. And they're the very same people that need some kind of social support for promoting health and well-being and managing disease. There's a wonderful article that was written several years ago in the BMJ. It's very short, 4 pages. You can download it, and I really think that it summarizes in a beautiful way the partnership with patients and families. Don was one of the lead authors of this article, Lucian Leap, Carolyn Clancy, head of our Agency for Healthcare Research and Quality, Jim Conway, and several other physicians. But they talk about, for the healthcare of the 21st century, really as a safety imperative, that patients are essential and respected partners in their care, but also in the execution of all aspects of healthcare. They talk in this article about that explicit commitment to patient and family-centered care. So in your practices in the community, is there something hanging on the wall, or is it a piece of paper that you share with all new patients that join the practice, or when you're hiring new staff that you say, this is the way we work, this is fundamental to our beliefs, and we want to make sure that you understand that as we work together. They also make a very important point that families should never be viewed as visitors, and that in our hospitals particularly, but also in your primary care practices, families can be a resource and support, and we need to change that concept of families as visitors, labeling them as visitors, to one where we support family presence and participation. And lastly, that the model of care in primary care really needs to be self-management support, supporting people with chronic conditions to support manage their care. I've been sharing with folks all week, I'm a fairly new type 1 diabetic. And when Maureen said those 5,000 hours, they had special meaning to me. And I'm thinking, my job while I'm here in New Zealand and with all the crazy change in hours, I'm managing my diabetes, and the rest of my healthcare team are very far away from me. And when my suitcase didn't arrive You all were so kind, and I was worried I was going to run out of needles, so we had a little needle exchange at the last meeting. Fortunately, I didn't need them, but I thought, I wonder what they think is happening here. I want you to look after today with new glasses at your practice. And actually on the website, there's some tools, one about how to do a walkabout. But I'm hoping you will look at it from the perspective of patients and families, and then invite some of your patients and families to work with you on improvement. So here is, I hope you can see it, this was actually in our country, a brand new renovated outpatient clinic. And they lined up all the chairs like rows in a bus stop facing the hallway away from the receptionist in the clinic waiting room. And you felt like a goldfish in a goldfish bowl before you ever saw a clinician. You really were disempowered. So I was there with a colleague and we moved all the chairs around, rearranged the whole waiting room. But guess what happened the next day? Back in those rows. It means that you've got to get everyone in your office, everyone on your team, including people that might help and do some of the cleaning, to understand you're trying to create a sense of welcome and support and a feeling that they're a partner in their care right from the beginning. Here's an emergency. So, you deal with patients who've experienced care in the emergency room and in the hospital. This is a sign I took in one of our urban hospitals that says, all patients must see nurse first, sit on bench till called by nurse. Sure doesn't set up a partnership to me. Now, at least we translated it into another language, but not, the stop sign, everything is, you're not in charge here, we are. And then we go to these wretched signs that, all visitors, please pick up wall phone and dial 1 for permission to enter. And then you wonder why people don't realize that they have a role in their own health care when you see them in primary care. At every step across the healthcare system, we have taken power away from patients and families. Rather than, I don't think we have to give power to them, we just have to not take it away by our practice. There's a wonderful new book, and I have it tucked in my luggage that I'm dragging around. I have a pre-publication edition of the Institute of Medicine's latest book on best care at lower costs. And I think it fits so much about all the discussions that we've had all this week. And they are describing the characteristics of a learning organization. And clearly a theme all the way through this publication is that we need to partner with patients and families. It's through the eyes of patients, but that doesn't mean that we just hop in their shoes and see it as they would, but I think we need to have them with us. And so they speak to involve patients and families in decision regarding health and healthcare tailored to fit their preferences. Patients and families should be given the opportunity to be fully engaged participants at all levels, including individual care decisions, health system learning and improvement activities, and community-based interventions to promote health. It's an untapped, amazing resource that I think can grow in your country and certainly can grow in our country. I think that the book goes on to talk about when patients, their families, other caregivers, and the public are full, active participants in care, health, the experience of care, and economic outcomes can be substantially improved. So again, we're back to engaging patients. In our country, and I think you all are beginning to talk about this, but you're so far ahead of us in terms of anchoring your healthcare system in primary care. We are really using the patient-centered medical home as a way to redesign primary care and redesign our payment incentives. And in the early work, when a few years ago, when the key primary care organizations came together to embrace these joint principles, they talked about a robust partnership in care, but also in quality improvement. I don't think they fully understood what that meant or what that looked like. I think their concerns were at first payment reform to have the right incentives, and I think that's very understandable. But I think we have that now, that we know we need to have this partnership. And there's a wonderful article by Charlie Homer and Rich Barron, who several years ago talked about the medical home is a radical, really change in mindset, that we have to educate people to it. I think you all have it deep in the way you practice. But I think the opportunity to partner more with patients and families to make it even better and to really look together, they can help you in reducing costs. Over and over again, we're learning from patients and families that they have less expensive solutions when we really understand what they want and what they need and what's important to them. Charlie Homer and Rich Barron also talk about the most important thing that people have done to refocus people's thinking is to put patients and families on improvement teams. There's a brand new report out from the Patient-Centered Primary Care Collaborative, PCPCC. I'm a brand new board member of that organization, and this report I had an opportunity to review and comment before it was released a couple of weeks ago. You can get it off of this website, and it might be interesting, again, for you to look at what some of the changes and what we're beginning to see with our newer approaches to primary care. So now I'd like to really talk about that, partners for improvement. We call them patient and family advisors. You may come up with other terms, but it's all about collaboration when you have them on your improvement teams with you. It's not that you just do what patients and families tell you to do, but it's about innovation happening together, that it's your idea and your idea and your idea coming together and figuring out what works for all. Because one of the things they want for their primary care providers is that you have joy in the practice. They don't want to be cared for by clinicians that aren't happy in the work. So it's listening to all those different perspectives. And a focus group and a survey, yes, they're good to do, but that's a one-way flow of information. When you have them at the table with you, when you're beginning to think about change and making change and evaluating the effect of change, that's when you get really new insights about the experience of care. You know, having someone like Gilbert with his experience as from healthcare, sitting at the table, making improvements to make it for the larger group, that's when we really get important in sustaining changes. Maureen was an author. I've talked about this article for so long, Maureen, and I'm so grateful that you wrote it with Jim Reinerston, a physician in Minnesota who's very committed to quality improvement. And when they edited it a few years ago, they added this extra lever for leaders, actually took out one and put this one in, and which really said leaders of high-performing organizations where they're getting stunning levels of improvement think the major change they're making is putting patients and families in real positions of power and influence where they can share their wisdom. This is not tokenism. This is not, oh, I talked to someone and now we'll go off and figure it out together, but they're really working together. I know you probably can't see, this is a large medical group in Oregon, the western part of our United States. Their in the top box on the left-hand side is their lead physicians in this multi-specialty practice. There are about 85 physicians in the practice. And to the right box is their finance, their quality committee, and their patient and family advisory council. All three of those link together to the leadership of the practice. And they developed a very simple recruiting form, a little postcard that doctors could think about who in their patient panel, who among their patients might be really good to help them make change in the practice. And it says on the card, these are the qualities we look for in a patient and family advisor. Someone who can share their story so others can learn from them, someone who is interested in improving healthcare, someone who is a good listener, someone who's interested in collaboration. And all the doctor has to do is to write, "Dear Mr. Jones," and sign the name. The patients feel very proud to be nominated by their physician to be an improvement partner. Some might not have time. But in doing this process, they got these wonderful ladies. And wouldn't you love to have some DVD divas in your practice? These are people who got their care in these practices. They had had some experiences that hadn't gone so well, and they really wanted to be part of making change and improvement. And the practice gave the council $5,000 to work with. And these smart women leveraged those resources and raised dollars in the community to make a series of DVDs. And they made one on your safety, one on your medications, and one on how to get the most out of your visit. They know you don't have all the time in the world with your clinicians, so how can you be efficient in those conversations? Do you see how their work together can benefit everybody? A long time ago, I was visiting this clinic in a very underserved area, and they wanted to partner with the women who had gestational diabetes in the practice and to help them actually teach residents to care for this largely Latino community where language was primarily Spanish and most people lived in poverty. And so they called them promotoras. It's what I would call patient and family advisors. And they helped redesign the flow of the practice. And then they went to every exam. It's the way I do site visits. And I go in and I see, what do I see? And this, every exam room had these great big posters that said, "Diabetes, take off your shoes." And they all felt, they said, we just feel dehumanized, not really respected. What if he said, "Show off your feet"? Now that's not a very expensive change, but it's a change in use of language and words that makes you feel differently. In San Francisco, this is a wonderful public clinic which serves Chinese and Russian families primarily, and this is a meeting of their advisors, and they planned the Walk and Talk series. And I often hear clinicians and other staff say, "We plan patient education things and people don't show up." Well, when you talk to patients and families and ask them to help you do it, they're getting ready to do the Walk and Talk. I don't know whether you can see that little tiny lady, she's about this high, she's 92 years old. She leads the Walk and Talk series. And sometimes they decide, we're not going to walk today, we're just going to talk about how we're working together and managing our diabetes. But what's really wonderful is, Lisa Golden is the wonderful family physician who's head of this clinic. And she talks about going to this advisory group, and it renews her commitment for the very hard work she does every day. It's not that she feels overwhelmed by the unreasonable requests of these patients and families. That just doesn't happen. She feels inspired and energized because of the work that they're doing in promoting their own health and well-being. Carl Cooley is a wonderful physician and has done the medical homework for more than 20 years, a real leader in our country. And he started with office-based quality improvement. Let's get one physician, a nurse, a care coordinator, the administrator, and a couple of patients and families, and that's our improvement team. We don't have to have a big structure, we're going to do it together. And that's been the foundation of his work. I've given you a couple of websites to go look. The American Academy of Pediatrics has a fabulous website on the medical home and partnering with patients and families, and also in teaching the next generation of physicians in this work. Dartmouth, yesterday we had a very powerful discussion, and certainly with your minister this morning, talking about we've got to figure out how to do this work at less expense. And one of the things that's so costly, certainly in our country, is you fill out form after form after form. I go back for my care, and every time I go back, I'm filling out the same information. And it's taking my time but it's also taking a whole lot of people that are pushing that paper all around. And so at Dartmouth, they actually asked their patients to help them figure out a system so that people didn't have to fill out all those forms so many times. And so they had the right information at the right places. They also asked them to help understand what access really meant to patients and families. They now have 130 advisors at Dartmouth. And this project gave new confidence to patients and families who were part of this endeavor. In Oregon also, they were working on the patient portal, the electronic health record, and they brought the patients in after they'd done quite a bit of work on it, and patients said, we can't find our medications on this. Where are they? Well, they had buried them so deep in the process that they couldn't find them. And so they redesigned the portal so it worked better for patients and families. I think if they'd started early on, they could have done that more efficiently and said, what's important to you and how do we design this so that you have access to it? I think an important thing here, though, is they've shown to help build a commitment to working with advisors. They showed the before and after, that what the portal looked like before you got patient input and then afterwards. Years ago, we had a contract with the Department of Defense to help do care coordination. And patients, first, the contract was about case management. First thing we learned from patients and families was they don't like to be called cases. They are people, and they wanted help with the care to help coordinate the care. And so we changed our language. We got patients and families to define what good care coordination would look like, to help write the job descriptions for those people, helped in the hiring process of those people. So you got, again, a system that really works for patients and families. ICSI is an Institute for Clinical Systems Improvement in Minnesota, wonderful organization doing very creative work. Earlier this week I had an opportunity to talk to some of you who are very interested in palliative care and end-of-life care. And they really wanted, what they were discovering was physicians didn't know how in primary care to talk to people about palliative care. And patients and families didn't know how to talk to their physicians about palliative care. So they started a really impressive project where they worked with clinicians in figuring out this pathway. And notice the words they use: planning, build rapport, tailor intervention, decision support, and reassess. They then said, well, I think we should work with patients and families on how we do this. And look at the difference in the language. Preparing, building a partnership, exploring options, making a decision, and reassess. So when you start from the beginning and work together, I think you get to better language and intent more quickly. So if we're learning to be efficient, to really be transparent and say, we want to learn to work together, we're going to start right at the beginning. Care coordination, there's wonderful data that if we just, for end-of-life care, if we just talk with patients and families and then support the choices that they want, that to me is a patient and family-centered approach to care. And here they were able to show that they saved $18,000 per patient. And it was also about quality of life and quality of the memories for families of what they had endured. But it's about respect and dignity, respecting their choices. This is a wonderful hospital. It's really what we would call a primary care hospital almost. It serves very underserved area north of San Francisco. And they were having trouble with people with mental health crises getting care in their emergency department. And the staff said, we're going to start a lean quality improvement. The CEO was very visionary and said, you cannot start that improvement project unless you have people with mental health issues and the community organizations part of the process. You just do wonders for this meeting. Thank you so much. And so together they worked on improvement, and over about 6 months. And here's, when you think about measurement and the meaning of measurement, they were able to reduce by 50% the number of people that left the emergency room without treatment. They were able to save 250 staff hours every month. They were able to reduce the aggression in the emergency department. And there are a number of additional measures that they looked at, but they also improved the quality of care. People went home on less psychotropic drugs. They went home with more complete discharge plans. Clearly a better way to work. And I think part of it was they had everyone at the table. The community, the patients and families, and the staff and clinicians and administrative leaders. This wonderful program in Moms program serves an underserved area, and I know I've talked to some of you who have community outreach workers embedded in the community, and this has done that and taken just a slightly different spin. They had both the non-traditional health workers, but they also had personal mentors, and they knew they had a problem with many two babies born exposed to drugs. And they were trying to, in this community, try to reduce this. And one of the key strategies they use is this personal mentor, who was someone from the recovery community, someone who had experienced addiction before. And she really supported these moms every day, taking her to appointments, helping her turn her life around. And these people, carefully selected, were trained in as counselors in this addiction program and in peer support. And the data looks like this. In 2005, there were 114 babies born who were addicted, in 2010, and in 2011. And not a single one of those 9 babies were part of this program. So it was the power of that peer support, someone who had that lived experience with addiction who was able to turn that around. Another really interesting program in our country is rural Colorado, where they have a research program that they've partnered with patients and families from the community, from the beginning of every research project. And they've worked on colonoscopy screenings and asthma prevention and management on the medical home and trying to enhance safety. And at the beginning of every project, when they work with their advisors, they have what they call boot camp. And the way they describe it to me is it's grand rounds that they stop every 5 minutes to explain what they've talked about. So they get the really in-depth information. And what has happened is these community advisors have helped get the research to be meaningful to these small practices and rural access hospitals. And this is where some of their members are going to the gun club to talk. I bet those members who live in that community would have more respect talking about colonoscopy screenings there than if I went. And what has happened, one of the ranchers, he can't go to the cattle sale barn without all his buddies coming up to him to describe their colonoscopies. So there's some impacts of this work, but they have found that their research has been significant because they've had the partnership with the community they serve. They've just won a very large PCORI grant to do more work about this partnership work, which I'm thrilled. But again, Jack Westfall, the physician, the family physician lead of this work, has said, you know, this has made our research 10 times better, plus it's a whole lot of fun to work with people from the community. So I hope you'll think about your practice now. We've talked a lot about different ways you could partner with patients and families, but that you would look at these domains, and on our website we have self-assessments of clinics organized in these domains. And I'm just wanting to show you very quickly, through the patient's eyes, a couple of things to think about in your practice before you do that walkabout. is there something that says hello, welcome in multiple languages that relates? This is in the Children's Hospital in Calgary, Alberta, that reinforces we're a partner, that you're a partner in your care, and that they give a business card with this message, and basically it's the core concepts of patient and family-centered care. In this clinic, it says, we care about you and your priorities. We are a team. And that's in the waiting room and in every exam room throughout the clinic. You all may know the wonderful work of Mara Stewart, a family physician from Canada, who published more than a decade ago that if we really listen to the patient's agenda, we get better outcomes and we save dollars. So how important to do that? And the work of Carl Dunst and Carol Trivet, where they talked about participatory involvement. Yes, we need to have technical skills and clinical quality, and we have help giver traits. That's really being nice to people, but it's that ability to engage patients that's so important. And I think when we talked earlier about it's important that the patient is encouraged to set goals. That's self-management support. And you can see here in this conversation, the computer is part of the conversation, that the sharing the story, getting the patient to affirm the story and work together to set goals. Clearly, the work of Kate Lorig has influenced, I think, all of us around the world and taught us that lay leaders, patients and families can provide education and peer support to people living with chronic conditions. A program you may not have heard about is called Team Up for Health. We did this work funded by the California Healthcare Foundation several years ago, and there's a wonderful website with lots of tools and video clips, and it's all about getting self-management support into the practice as the standard of care. And this is the strategies that we used in terms of change, and we were on the faculty to help them partner with the patients and families. And one of the things we learned from patients and families is the waiting room should not be a place of waiting, it should be a place of learning. And so thinking about what you could do, and one of the things that this particular clinic did is they developed a sheet to help the patient. I loved your diabetes cards, and this is just another way of looking at it to organize your thoughts so you can make sure your agenda is considered first. That picture of the patient and the physician with the computer in between them, they have it so that the patient's goals pop up first on the clinical record, so that informs the discussion. And how do you learn to do this? You can learn with patients and families as part of the teaching team. And that's how Sammer is a wonderful primary care physician, and Ross is one of his patients, and they're role-playing this new way of working with motivational interviewing and asking open-ended questions. And lastly, one other project that was in this same Team Up for Health initiative, they even partnered with patients when they selected the new chief medical officer. They wanted someone not only who had the clinical skills, but had the attitude to work with this particular community, who would be able to work with really a sense of respect and a sense of building on the strengths of this community. I hope I've shared with you enough to show you that this actually can become your business model. That partnering with patients and families, and really at all levels of your organizations, will impact finances, quality, safety, and not just the satisfaction of patients and families, but of all who work in your clinic. So to leave you just with a couple of ideas, and all of these slides and several different handouts on how to get started with this work, I think to look to your practice and say, who would you like to work with as a partner in improvement? And identify a few people, and if it's a large practice, identify several staff and clinicians to work together informally and try to find some tangible things to get started on. And it could be, the very first thing is to do a walkabout around the practice and look at it from the perspective of patients and families. And when you have them side by side, you'll gain lots of new insights. But if you're planning to renovate the clinic, involve them in that. If you're planning to develop some new educational programs or materials, involve them in that. If you're wanting to develop a website and send messages on smartphones, Don't do it without having patients and families part of it. And certainly if you're transitioning to use technology more, they should be part of the process. So thank you very much. I hope I've shared some ideas. Really changing the culture of an organization. It's a journey, not a destination. But leadership is key. And I see each of you as leaders for primary care, which really sees the system of care from the perspectives of patients and families. Thank you very, very much.